Today's episode features the blog post titled 12 Key Principles for Diagnosing and Managing Vertigo and Dizziness. Dizziness is one of the most common and diagnostically challenging complaints we encounter in clinical practice. The imprecise way patients describe their symptoms often complicates the process. It can make it hard to tell the difference between a benign peripheral condition and a life-threatening central cause, like a stroke. Effective management requires a systematic approach. Our first principle highlights that the diagnostic approach to dizziness should prioritize understanding the timing and triggers of symptoms over relying solely on the patient's qualitative description. This is because a patient's description is often imprecise and unreliable for telling different causes apart. Frameworks like titrate, which stands for timing, triggers, and targeted examination, provide a systematic method that is more reliable than simply asking patients to describe the sensation. The initial step is to classify the timing into distinct syndromes. Acute vestibular syndrome, or AVS, is defined by the acute onset of continuous vertigo, nausea, gait instability, and nystagmus, lasting from days to weeks. This must be distinguished from episodic vestibular syndromes, which involve transient, recurrent episodes. Episodic syndromes are further divided by their triggers. Triggered episodes, such as those caused by head position changes in BPPV or by standing in orthostatic hypotension, have a clear precipitant. In contrast, spontaneous episodes occur without a clear trigger. We see these in Meniere's disease, vestibular migraine, or TIA, or transient ischemic attack. Finally, chronic vestibular syndrome involves continuous symptoms for weeks to years. This can follow an unresolved AVS, or it might indicate a primary neurologic disorder, such as persistent postural perceptual dizziness, or PPPD. A critical distinction here is whether head movements trigger vertigo, which suggests an episodic syndrome like BPPV, versus whether they exacerbate ongoing vertigo, which is characteristic of AVS. Our second principle focuses on the HINTS exam. HINTS stands for Head Impulse, Nystagmus, and Test of Skew. This is a critical bedside tool for differentiating acute vestibular syndrome due to a peripheral cause, like vestibular neuritis, from a central cause, like a posterior circulation stroke. It should only be performed on patients with ongoing, continuous vertigo and nystagmus. The utility of the HINTS exam is strictly limited to patients with active AVS. Performing it on those with triggered or resolved vertigo can be misleading. A reassuring HINTS exam, suggesting a peripheral cause, consists of an abnormal or positive head impulse test with a corrective saccade, unidirectional horizontal nystagmus that suppresses with fixation, and no skew deviation. Conversely, a dangerous HINTS exam, suggesting a central cause, often remembered by the mnemonic impulse normal, fast phase alternating, refixation on cover test, includes any one of the following: a normal or negative head impulse test, direction-changing nystagmus, or the presence of skew deviation. Research has shown that a properly performed HINTS exam has higher sensitivity for stroke in AVS patients than early MRI, especially within the first 24 to 48 hours. The HINTS Plus modification adds an assessment for new-onset unilateral hearing loss. If present, this should raise suspicion for an anterior inferior cerebellar artery, or AICA, territory stroke. The third principle addresses posterior circulation stroke. This type of stroke, such as a cerebellar or brainstem infarction, can manifest as an acute vestibular syndrome. It must be diligently differentiated from more benign peripheral causes. Key indicators for a central cause include a dangerous HINTS exam, associated focal neurologic deficits, often called the dangerous Ds, like dysarthria, dysphagia, diplopia, or dysmetria, severe gait ataxia, especially an inability to walk unassisted, or a new severe headache. While many strokes present with overt neurologic signs, approximately 10% can present with isolated vertigo, particularly in the early stages. A normal head impulse test in a patient with AVS is a powerful predictor of stroke. Other highly concerning signs for a central lesion include purely vertical nystagmus or skew deviation. Clinicians should also assess for marked truncal or gait ataxia that seems disproportionate to the patient's subjective vertigo, as this strongly suggests a cerebellar lesion. MRI with diffusion-weighted imaging, or DWI, is the preferred imaging modality. However, it can be falsely negative in 15 to 20% of posterior circulation strokes within the first 24 to 48 hours. A non-contrast head CT is largely insensitive for acute ischemic stroke in this region, but it can rule out hemorrhage. While traditional risk factors increase suspicion, posterior circulation strokes can occur in younger patients without these risk factors, often due to vertebral artery dissection. Moving on to our fourth principle, we discuss central nystagmus patterns. These patterns are indicative of brainstem or cerebellar dysfunction. They often include purely vertical, meaning upbeating or downbeating nystagmus, purely torsional nystagmus, direction-changing gaze-evoked nystagmus, which means nystagmus that changes its fast phase direction with the direction of gaze, and nystagmus that does not suppress or may even worsen with visual fixation. These patterns contrast sharply with peripheral nystagmus, which is typically unidirectional, predominantly horizontal torsional, and suppressed by visual fixation. The inability to suppress nystagmus with visual fixation is a hallmark of a central origin. Clinicians may need to use Frenzel goggles or a pen light cover to observe peripheral nystagmus clearly. Specific central patterns can point to the location of the lesion. Persistent downbeating nystagmus is often associated with lesions at the craniocervical junction, such as Chiari malformation. Persistent upbeating nystagmus can be caused by lesions in the medulla, pons, or cerebellum. Direction-changing gaze-evoked nystagmus, for example right beating on right gaze and left beating on left gaze, is a strong indicator of central pathology, often cerebellar, and is a key dangerous finding in the Hintz exam. Our fifth principle covers vestibular neuritis. This condition presents as an acute vestibular syndrome with the sudden onset of severe, continuous vertigo, nausea, vomiting, and gait instability. It typically lasts for several days to weeks, often following a viral prodrome. It is distinguished from stroke by a reassuring Hintz exam. The underlying cause is inflammation of the vestibular portion of the eighth cranial nerve, leading to acute unilateral vestibular hypofunction. When associated with unilateral sensory neural hearing loss or tinnitus, the condition is termed labyrinthitis. The characteristic physical finding is spontaneous unidirectional nystagmus that beats away from the affected side and increases in intensity when looking toward the fast phase. This is known as Alexander's law. Critically, the head impulse test will be abnormal or positive when the head is thrust toward the affected side. Treatment is primarily supportive. A short course, typically 3 days or less, of vestibular suppressants and antiemetics can manage acute symptoms. However, prolonged use of suppressants should be avoided as it impedes central compensation. Corticosteroids may be considered if initiated within 72 hours, though evidence for long-term benefit is mixed. Vestibular rehabilitation exercises are crucial for promoting central compensation and accelerating recovery. Next, our sixth principle discusses benign paroxysmal positional vertigo, or BPPV. This condition is characterized by brief episodes of vertigo, typically lasting less than 60 seconds, often between 10 and 30 seconds. These episodes are triggered by specific changes in head position relative to gravity. BPPV is diagnosed by the Dix-Hallpike maneuver for posterior canal BPPV and treated effectively with canalith repositioning maneuvers, such as the Epley maneuver. The condition is caused by displaced otoconia, which are calcium carbonate crystals that have migrated into a semicircular canal, most commonly the posterior canal, accounting for 80 to 90% of cases. The Dix-Hallpike maneuver is diagnostic for posterior canal BPPV. It elicits transient vertigo and a characteristic upbeating and torsional nystagmus after a brief latency. The first-line treatment is the Epley maneuver, a highly effective procedure to guide the otoconia back into the utricle. Horizontal canal BPPV accounts for 5 to 15% of cases. It is diagnosed with the supine roll test and treated with maneuvers like the Lempert or barbecue roll. Importantly, vestibular suppressant medications like meclizine are generally not recommended for routine BPPV management. They do not address the underlying mechanical issue and can delay recovery and increase fall risk, especially in older adults. The seventh principle covers Meniere's disease. This disease is characterized by spontaneous, recurrent episodes of vertigo lasting from 20 minutes to 12 hours. These episodes are accompanied by fluctuating unilateral sensory neural hearing loss, which is often low frequency initially, tinnitus, and a sensation of oral fullness or pressure in the affected ear. The pathophysiology is believed to involve endolymphatic hydrops, an abnormal accumulation of endolymph in the inner ear. Formal diagnostic criteria, such as those from the Barony Society, require at least 2 spontaneous vertigo episodes lasting from 20 minutes to 12 hours, audiometrically documented low to mid-frequency sensory neural hearing loss, and fluctuating oral symptoms in the affected ear. Over time, the hearing loss can become permanent and progressive. Management of acute attacks involves symptomatic relief with vestibular suppressants and antiemetics. Long-term strategies aim to reduce attack frequency and severity through lifestyle modifications, such as a low-salt diet of less than 2 grams per day, reduced caffeine and alcohol, and medical therapy, such as diuretics or beta-histine. For refractory cases, intratympanic steroid injections, ablative gentamicin therapy, or surgery may be considered. Our eighth principle addresses vestibular migraine. This is a common cause of recurrent spontaneous episodic vertigo. It is diagnosed based on a history of migraine headaches, meeting International Classification of Headache Disorders criteria, with or without aura. It also includes episodes of vestibular symptoms, such as vertigo, dizziness, or unsteadiness, lasting from 5 minutes to 72 hours, with at least 50% of these episodes being associated with one or more migrainous features. The vestibular symptoms can occur before, during, after, or entirely independent of the headache. Accompanying migrainous features include a migraine-type headache, photophobia, phonophobia, or visual aura. The diagnosis is clinical, often made after excluding other causes. Unlike Meniere's disease, persistent hearing loss or constant tinnitus is typically absent. Management strategies mirror those for other forms of migraine. This includes lifestyle modifications to avoid triggers, acute therapies like triptans and NSAIDs, and prophylactic medications for frequent episodes, such as beta blockers like propranolol, antidepressants like amitriptyline, anticonvulsants like topiramate or CGRP inhibitors. The neurological exam is usually normal between attacks. The ninth principle covers orthostatic hypotension. This is a frequent cause of presyncopal dizziness, meaning lightheadedness or a feeling of impending faint. It is defined as a sustained drop in systolic blood pressure of greater than or equal to 20 millimeters of mercury, or a drop in diastolic blood pressure of greater than or equal to 10 millimeters of mercury, occurring within 3 minutes of changing from a supine or sitting position to a standing position. Symptoms typically include lightheadedness, blurred vision, weakness, or feeling faint, provoked by standing and relieved by lying down. Etiologies can be neurogenic, for example Parkinson's disease or autonomic neuropathy, or non-neurogenic, most commonly due to volume depletion or medication effects like antihypertensives, alpha blockers, or diuretics. Evaluation requires a careful medication review and meticulous measurement of orthostatic vital signs. Management focuses on treating the underlying cause. Non-pharmacologic measures are first line, including increasing fluid and salt intake, using compression stockings, and performing counterpressure maneuvers. For refractory neurogenic orthostatic hypotension, pharmacologic therapy with agents like midodrine, fludrocortisone, or droxidipa may be necessary. Our 10th principle is about medication-induced dizziness. This is a frequent and often reversible cause of dizziness. It encompasses various mechanisms, including ototoxicity leading to vestibulopathy, cerebellar toxicity causing ataxia, induction of orthostatic hypotension, sedation impairing balance, or direct vestibular suppression. A meticulous review of all medications, including over-the-counter and herbal products, is essential in any patient with new or worsening dizziness. Aminoglycoside antibiotics such as gentamicin can cause irreversible bilateral vestibulotoxicity, leading to oscillopsia and severe imbalance. Other common culprits include antihypertensives, which cause orthostatic hypotension, anticonvulsants like phenytoin, which cause cerebellar ataxia, and sedatives like benzodiazepines, which impair balance. Alcohol is another common neurotoxin that can cause both acute vertigo and chronic cerebellar degeneration. In many cases, symptoms can be resolved or significantly improved by discontinuing or reducing the dose of the offending medication. This highlights the importance of identifying iatrogenic causes. The 11th principle discusses persistent postural perceptual dizziness, or PPPD. This is a chronic functional vestibular disorder characterized by persistent non-vertiginous dizziness, unsteadiness, or non-spinning vertigo that is present on most days for 3 months or more. It is typically exacerbated by upright posture, active or passive self-motion, or exposure to complex or moving visual stimuli such as crowds or busy patterns. This condition often develops after an acute event that caused dizziness, such as BPPV or vestibular neuritis. However, the symptoms persist long after the initial trigger has resolved. The pathophysiology is thought to involve maladaptive changes in postural control, an over-reliance on visual cues, and altered central processing of spatial information, often linked to heightened anxiety. Diagnosis is clinical, based on established criteria from the Bharani Society, after excluding other active conditions. Treatment is multimodal and highly effective, combining vestibular rehabilitation therapy, or VRT, to recalibrate balance, cognitive behavioral therapy, or CBT, to address maladaptive behaviors, and medications, such as SSRIs or SNRIs, to modulate central sensory processing. Finally, our 12th principle focuses on older adults. In this population, dizziness is frequently multifactorial, and there is an increased likelihood of serious underlying causes, such as stroke or significant cardiovascular disease. Therefore, a comprehensive assessment is crucial. This includes a detailed medication review, evaluation for sensory deficits such as vision, hearing, and proprioception, and a careful neurologic and cardiac examination. Dizziness in this population is rarely due to a single cause. Age-related degeneration of the vestibular, visual, and proprioceptive systems combined with musculoskeletal decline creates a high baseline risk. Polypharmacy is a major contributor, increasing the risk of medication side effects and orthostatic hypotension. The incidence of central causes like stroke is significantly higher, and presentations may be atypical, warranting a lower threshold for neuroimaging. While BPPV is also more common with age, it is critical not to default to this diagnosis without a thorough evaluation. The primary management goal in this population is fall prevention, as falls can lead to devastating consequences. A comprehensive geriatric assessment and targeted interventions like balance training are essential. In conclusion, a structured, systematic evaluation is paramount for navigating the complexities of dizziness. By focusing on symptom timing and triggers, proficiently applying bedside examinations like the Hintz test, and maintaining a high index of suspicion for central causes, clinicians can significantly improve diagnostic accuracy. Understanding the distinct profiles of common peripheral, central, and systemic etiologies allows for targeted management that enhances patient safety and improves long-term outcomes.